Proton versus photon therapy for oropharyngeal cancers, a new standard of care. Welcome back to the Head and Neck Oncology Journal Club. I'm bringing you a landmark trial that may change how we think about radiation therapy for oropharyngeal cancer. This is the first phase 3 randomized trial directly comparing proton therapy to photon therapy for oropharyngeal cancers, and the results are striking. Let's dive in. The paper is from Stephen Frank and colleagues, published in the Lancet in December 2025. Here is the clinical context. Intensity modulated radiation therapy, or IMRT, with concurrent chemotherapy is the standard of care for oropharyngeal cancer. But it comes with significant toxicity. In the cooperative group trials, over 60% of patients develop severe malnutrition and become feeding tube dependent. Previous de-intensification attempts, namely swapping cisplatin for cetuximab, reducing radiation dose, and using the surgery instead, have all failed to improve the outcomes. Proton therapy offers a different approach. By using charged particles instead of X-rays, intensity modulated proton therapy, or IMPT, can deliver the same dose to the tumor while dramatically reducing the radiation exposure to the surrounding normal tissues. The question was, does this physical advantage translate into clinical benefit? This phase 3 trial enrolled 440 patients across 21 US cancer centers. All had stage 3 or stage 4 oropharyngeal cancer. 95% of patients were HPV positive, and patients were randomized 1:1 to receive either IMPT or IMRT, both with concurrent systemic therapy. 91% of patients received platinum-based chemotherapy. There's an important wrinkle here. About 23% of patients crossed over between treatment arms after randomization, mostly due to insurance denials for proton therapy or insurance approvals that led patients to refuse their randomized IMRT assignment. The investigators anticipated this and designed the trial accordingly. Now for the results. At the median follow-up of 3.2 years, IMPT was non-inferior to IMRT for the primary endpoint of progression-free survival. 3-year progression-free survival was 82.5% with protons versus 83.0% with photons. 5-year progression-free survival was 81.3 versus 76.2. The hazard ratio was 0.88 with a p-value of 0.005 for non-inferiority. But here is where it gets interesting. Overall survival favored proton therapy, but this was a secondary endpoint. 5-year overall survival was 90.9% with IMPT versus 81% with IMRT. That's a hazard ratio of 0.58, a 42% reduction in the risk of death with a p-value of 0.045. Disease control rates were similar between the groups. Local recurrence at 5 years was 2.9% with protons versus 5.6% with photons. Regional and distant failure was essentially identical. So why the survival difference? The investigators point to the toxicity. Treatment-related deaths occurred in 9 patients, that is 6 in the IMRT group and 3 in the IMPT groups. Deaths after disease progression occurred in 27 patients, 18 with the IMRT group and 9 with IMPT group. Patients treated with photons appear to be dying faster after recurrence than those treated with protons. The toxicity differences were substantial. Grade 3 to 4 lymphopenia occurred in 89% of IMRT patients versus 76% of IMPT patients. Severe dysphagia was 49% versus 34%. Severe xerostomia was 45% versus 33%. And critically, feeding tube dependence at 60 days was 40% with IMRT versus 27% with IMPT. That's a 33% relative reduction. There were important limitations. 23% crossover between arms complicates interpretation, largely due to the insurance issues, as this trial itself demonstrated. Geographic access was limited to the centers with proton therapy capability, predominantly academic centers, and 93% of the patients were whites, limiting generalizability. The authors acknowledge that while proton therapy has had regulatory approval since 1988, regulatory clearance does not guarantee financial coverage for specific indications. Patients are often denied access based on the individual insurance coverage policies. Here's the bottom line. This trial establishes IMPT as a new standard of care option for oropharyngeal cancer, non-inferior disease control, significantly reduced toxicity, and an unexpected but welcome improvement in overall survival. The practical challenge is access. Proton therapy centers remain limited and insurance coverage remains a barrier, as this trial itself demonstrated. But for the patients who can access it, proton therapy now has level 1 evidence supporting its use in oropharyngeal cancers. That's your podcast summary. The full citation and the link are in the show notes. Until next time, this has been Head and Neck Oncology Journal Club. Thank you.